Hello everybody, good morning or good afternoon or good evening, depending on where you are exactly located on the globe. My name is Helena Silman Cohen. I'm the education lead of the International Physical Therapists for Hospice, Palliative Care, Oncology, and HIV/AIDS, or for short, the IPT-HOPE. And I would like to welcome you and the presenter to this session. This webinar will be recorded and uploaded to the IPT-HOPE website and will be available for everyone. I'm now gonna pass the floor to Dr. Matt Harville, who will introduce our presenter for today.
Hi, everyone. Thanks for coming. I do ask if you haven't already to mute your mic, but today we'll be listening to Dr. Levin Chetty, and he'll be discussing the development of exercise guidelines for aging populations living with HIV in South Africa.
Thank you, Dr. Harville, for that. So, guys, we're just having a bit of an issue with our bandwidth at the university. So I'm going to mute my video, but I'm going to actually present via my PowerPoint presentation. So just let me know when you guys can see this. There we go. There we go. Is that okay? Can you guys view that?
Yes.
Perfect. Okay, so I'm all set and ready to go. Okay, thank you, Dr. Harville, for that warm welcome. Good day, everyone, and thank you for attending the session today. I must say it's an absolute pleasure to be presenting to you today. So as much as the title on the slide introduces the topic for discussion today, I thought I'll also just provide an insight into my PhD project. And I hope that this gives you a sense of my PhD journey as well. So first and foremost, just a little bit about where I'm from. I'm from a little port town called Durban. Durban is situated in the province of KwaZulu-Natal on the east coast of South Africa. And if you have not already had the opportunity to visit our shores, please do so. I promise you, you will not be disappointed. So KwaZulu-Natal is the second most populated of South Africa's 9 provinces and is one of the most popular holiday destinations in the world. As you can see from this slide, it is synonymous with a range of landscapes from beaches to mountains and forests, and we're also known for our rich, diverse cultural heritage. Our wonderful coastline is washed by the warm Indian Ocean, which stretches from a little town called Port Edward in the south and all the way north to the border of Mozambique. In addition to our magnificent coastline, we also have the sweeping savanna in the east and the majestic Drakensberg mountain range in the west. So you can see we are blessed with some of the most breathtaking landscapes in the world. Our subtropical climate also means that the weather is fine throughout the year. So you can visit at any time throughout the year. So no excuses. You have to plan a visit to our shores at some time in your life. So just a little introduction and background to the study. And what do we already know? Firstly, the global response to the HIV pandemic represents one of the greatest public health achievements to date. We know that with the advent of antiretroviral therapy, life expectancy has increased. Since 2013, annual HIV-related deaths have decreased by 43% worldwide. In Southern and Eastern Africa, treatment has more than doubled since 2010. And since 2010 to date, HIV-related deaths in this region have decreased by 36%. In fact, by 2020, South Africa had already achieved the first of the UN AIDS 1990 targets by diagnosing 90% of people living with HIV in the country. Now, from that, we can deduce that people living with HIV are living longer, but the majority of HIV research only includes adults up to the age of 49 years. And for me, this was a very interesting scenario because it begs the question, what quality of life do people have as they age with HIV? One of the pioneers in the field of gerontology, Dr. Edward Stiglitz, once said, "It is not about how many years you have in your life, but how much life you have in your years that is most important." From a physical activity and exercise perspective, we know that physical activity can positively influence the outcomes in conditions such as HIV, since most older adults with chronic conditions prefer quality of life over longevity. It has the potential to improve many immune parameters, reduce the risk of acute infection, and combat metabolic abnormalities. There's also a strong correlation between physical activity and quality of life, level of vitality, and also physical and cognitive health in older populations. However, there is no clear recommendations to guide exercise prescription for older people living with HIV, especially in resource-constrained communities in low to middle-income countries. Now, some may argue that the American College of Sports Medicine does provide some guidance. However, it is not yet possible to describe in detail exercise programs that can optimize physical function and health in all groups of older adults, let alone those aging with HIV. And we also need to consider different contexts and environments. In this case, our study focused on resource-constrained communities in low to middle-income countries. So the methodology of the project was guided by the learning in action approach, and this set the tone for the conceptual framework and the theoretical framework that underpinned the study. For me personally, this was an important part of my PhD journey. When I decided to do this PhD, I was looking for something to challenge me and be impactful to society. But at the same time, I was afraid that undertaking a PhD of this nature would consume me. But I'm extremely thankful to both my supervisors for supporting this approach. I can see that both of them are present and listening in today. So a big thank you to Professor Varusia Chetty and Professor Saul Cobbing for their guidance and leadership. During many sleepless nights, I would often joke and phone them and tell them that the acronym for PhD was a permanent head damage. But I must say that their guidance made the journey enjoyable, but at the same time, very challenging. It helped me to grow. It contributed significantly to the areas of research that is close to my heart, and that is physical activity, gerontology, and HIV. Just to reflect on the interactive learning approach. This approach aims to solve complex societal challenges in a sustainable way. It does this by drawing on the knowledge and expertise of multiple stakeholders from different backgrounds, by exploring their perspectives, their needs, and their concerns. In other words, it uses a transdiscipline approach to move beyond the confines of the academic world and bridge the gap between science, policy, practice, and society. In this way, it makes research and innovation more responsive to the needs of society. It adopts a logical design which is introduced by problem identification, followed by action planning, implementation, evaluation, and reflection. So fundamentally, the knowledge gained from the initial cycle of data collection feeds into the planning of the subsequent research phases. So this approach takes any social practice or problem that may require improvement as its focus, and then the study unfolds, not according to a blueprint, but through a recurring process of planning, action, observing, and reflecting. In my particular project or this PhD, the social practice requiring improvement was the lack of physical activity and exercise prescription for older people living with HIV in a semi-rural setting. Now, this might seem a little bit daunting to you guys, but I'm going to try and explain it to the best of my ability, okay? So the conceptual framework for the study was derived from the initial analysis of the problem. The theoretical assumption was that policy, as well as personal and social factors, influence physical activity and exercise prescription for older people living with HIV. The problem analysis was derived by understanding the factors that influence the lack of physical activity and exercise prescription for this population in a resource-constrained context. So in Figure 1, it shows the intersection of the factors that influence the lack of physical activity and exercise prescription within the study context. It also highlights the underlying reasons for a lack of such interventions. What the problem analysis revealed to us was that the intersection of factors such as poor governance, poverty, HIV-related disability, and stigma expose 4 dominant theoretical concepts. So I've tried to highlight each of these concepts in a different color just to make it a little bit easier to understand. So you'll see that the first concept, which is highlighted by a lighter shade of yellow, relates to policy or inadequacies in the healthcare system. That could be most probably as a result of the biomedical approach to HIV care. The second, third, and fourth concepts, which are highlighted by lighter shades of green, blue, and pink respectively, relate to environmental, economic, social-cultural, and HIV-related patient factors. While the policy or inadequacies of the healthcare system pointed to service provision limitations, the environmental, economic, social-cultural, and patient factors highlighted the inequities that's been imposed on this population, a very vulnerable population. The conceptual framework, which is represented in Figure 2, highlights the implications of a lack of physical activity and exercise prescription for older people living with HIV. Interventions such as physical activity and exercise prescription, especially in chronic conditions, are often viewed through the lens of the biomedical approach to healthcare, without integrating contextual factors such as policy or healthcare inadequacies, intrinsic inhibitors, and also environmental precursors. Policy or healthcare inadequacies highlight the need for policy guidelines and proper implementation of healthcare systems to drive structured physical activity and exercise uptake in older HIV populations. The intrinsic inhibitors and environmental precursors highlight the predisposing factors that lead to feelings of inadequacy and hopelessness, and eventually non-participation in physical activity and exercise interventions within this population. What our study revealed at this stage was that even within medical specialities, there's a significant variability between individual interclinicians in how physical activity and exercise are prescribed to specific patient groups. We also found that interventions are generally on a single encounter basis and are often inadequate to drive changes in exercise management and function in this population. There is therefore a need for health professionals to be effectively trained to promote physical activity and to prescribe exercise. And the lack of an intervention may not only contribute to a decreased quality of life, but also to the social marginalization of older people living with HIV. So the conceptual framework recommended 4 measures that can positively influence physical activity and exercise prescription outcomes in this population. And I'm going to go through each of them now. So firstly, the development of a structured exercise prescription was viewed as the critical initial step in encouraging participation. Secondly, monitoring of participants through adequately supervised exercise sessions could be considered beneficial to improving patient outcomes and well-being. Thirdly, the effective training and upskilling of healthcare professionals should be regarded as the vital element that can ensure long-term adherence to such interventions. And fourthly, by addressing the gaps in current policy, it may be possible to satisfy this population's basic need for social belonging, to maintain their identity, physical well-being, and their mental health as well. So the conceptual framework, which was derived from the analysis of the problem, enabled the development of the theoretical framework that linked to the conceptualization of the study, and this I've actually presented in Figure 3. The conceptual framework highlighted the policy or healthcare system inadequacies, as well as the environmental, economic, social, cultural, and HIV-related patient factors that can limit physical activity and exercise prescription. This allowed us to position the study at the intersection of 2 very important theoretical constructs. The first one was the conceptual framework for aging with HIV in sub-Saharan Africa, and the second was the social justice theory. Just a little feedback on both of those theories. The conceptual framework for aging with HIV in sub-Saharan Africa incorporates a syndromic approach to gerontology, and it includes domains of physical, cognitive, and social functioning as well. It draws on an important locally relevant elements such as HIV stigma within an African context. And this is important because this often disrupts access to social support mechanisms in this population. The framework intends to serve as a launching point for future work, both to validate and to alter conceptualizations regarding HIV and aging. It also seeks to further prioritize public health and research domains for older people living with HIV in the sub-Saharan region of Africa. The framework also suggests that the determinants of quality of life among older people living with HIV in rural Africa differ significantly from those in the Western world, and that highlighting these determinants and their relative contributions is very essential in developing effective interventions to optimize their health. For older people living with HIV in a marginalized South African community, limited access to rehabilitation actually infringes on their right to quality healthcare. Therefore, viewing and conducting the study through a social justice lens was absolutely necessary. The social determinants of health are not only defined by a person's social and physical environment, but also their access to healthcare services and interventions. Poverty and stigma are some of the most significant social determinants of health in HIV patients. And the aim of the social justice theory is to promote and improve the conditions of the disadvantaged. What we actually did in this project was take the principles of social justice and apply it to the methodology in order to advocate for improvements in healthcare treatment options and accessibility for this population. I'd just like to introduce you guys to the research site where the study unfolded, something very dear to my heart and our research group. The study setting was a low socioeconomic semi-rural district called Marion Hill. It is located on the periphery of the city of Durban in KwaZulu-Natal. The area itself is serviced by a 200-bed level 1 district hospital called St. Mary's Hospital. The public hospital serves as a population for approximately 1 million people and acts as a referral for 16 primary health clinics and 2 community health centers. It provides a service for approximately 4,500 people living with HIV in a semi-rural area, although estimates indicate that more than 250,000 people, that's almost about 33% of that population, that are living in that area are living with HIV. And a substantial percentage of these individuals are greater than the age of 50 years. So just to highlight the objectives and the outcomes of the project, and I'd just like to mention at this stage that each of the objectives culminated in a research publication. So at the end of this presentation, you will see a slide with all of these publications, which are available for you to engage with online. But if you have a problem accessing it, then just drop me an email and I'm happy to email it to you as well. So let's look at those objectives. Objective 1 was to review the existing literature and current exercise prescription outcomes in this population. It was also to identify key criteria and aspects of care in the context of HIV exercise rehabilitation. What the review confirmed was that the benefits of physical activity and exercise are there, but it highlighted the dearth of evidence for physical activity and exercise rehabilitation in the context of older people living with HIV and those in resource-constrained areas. It reaffirmed the need for further research to guide the design and implementation of improved exercise rehabilitation options for this population, specifically the parameters of frequency, intensity, time, and type of exercise that may be most beneficial for this population. The review also advocated for the inclusion of a wider range of assessment measurements, such as tools that investigate the population's full participation in activities of daily living and the cost effectiveness of physical activity and exercise interventions. Objective 2 was to explore the experiences, the perceptions, and recommendations of older people living with HIV regarding physical activity and exercise. This phase highlighted the motivators and the barriers to exercise participation from the very perspective of those who are living with the disease and are over the age of 50 years. Recommendations from healthcare professionals, personal gratification, and the ability to perform activities of daily living, as well as participating in community activities, were believed to be strong motivators for exercise participation, while the barriers to exercise were attributed to physical health issues, lack of proper instruction, environmental factors, and the stigma associated with their HIV status among their families and their communities. So stigma is a big thing in HIV research at the moment. I think it's always been there, and it's something that keeps coming up all the time. And again, we are viewing it. This phase also noted that older people living with HIV preferred a combination of aerobic, flexibility, and strength activities, as well as adequate supervision and instruction within a group exercise setting rather than the individual exercise experience. Let's move on to Objective 3. So Objective 3 sought to explore the experiences, perceptions, and recommendations of healthcare professionals regarding physical activity and exercise for older people living with HIV. In addition to identifying the factors that influence exercise adherence and general considerations and recommendations for exercise prescription, this phase also highlighted the importance of the multidisciplinary healthcare team. The healthcare professionals at this stage also stressed the need for continual physical assessment and the provision of a conducive environment for exercise. In addressing Objectives 2 and 3 of the study, qualitative research methods in the form of interviews and focus group discussions were used to gain insights to inform the development of the framework to guide exercise prescription. The results of the interviews and the focus group discussions were used to inform the design of an inclusive model of exercise prescription for older people living with HIV. There was also agreement among the stakeholders that the framework needed to respond to policy, improve access to patient-centered prescription, and maintain a multidisciplinary team approach. Efficient communication and collaboration between all stakeholders were viewed as vital guiding principles. The training of professional staff and lay personnel with task-shifting approaches were also viewed as an essential part of the implementation. The health facility, intermediate clinics, community-based and outreach centers, and home-based rehabilitation were also identified as important settings where we can carry out such interventions. The focus of Objective 4 was to obtain expert consensus on exercise prescription for older people living with HIV. And this was achieved through engaging experts in the field of exercise and HIV, who were consulted to participate in a modified Delphi study. So in this phase, consensus was reached on a multifaceted exercise prescription, including elements of a warm-up, endurance, resistance, and cool-down activities, with incremental progression in intensity and volume. Our experts also agreed that appropriate infrastructure, adequate space for training activities, adequate training resources and equipment, optimal communication between all stakeholders, health promotion and education, and outcome indicators were essential to the model, while multidisciplinary engagement and collaboration, skill development of healthcare professionals, task shifting, pre-participation health screening, and monitoring and evaluation were seen as the fundamental principles for optimal care. Again, the acute hospital, the clinic, the home, and the community settings were all recognized by our expert panel as important elements for inclusion in the framework as well. The exercise prescription model, which included elements that were identified in the aforementioned phases of the study, was then developed, and I will show you that in the next slide. But this ultimately fulfilled Objective 5, which was to propose and develop an exercise prescription model for older people living with HIV in a semi-rural South African setting. So this is the model that was developed following the preceding phases of the study. You will see that the model places an emphasis on the need for structured exercise prescription at various points of care. So exercises should be offered within the home, the clinic, in community settings, in hospital settings, with supervision provided by the appropriate healthcare professional at each of these settings. And by utilizing a task shifting strategy, community healthcare workers who are believed to be essential to the sustainability of the model can be capacitated through appropriate training and supervision by the multidisciplinary team. The fundamental principles which are also presented in this figure are essential to the improved and seamless delivery of the exercise prescription. And I hope you guys can see that at the bottom there. So the exercise prescription itself was developed in harmony with the current recommendations by the American College of Sports Medicine, exercise management for persons with chronic disease and disabilities, and also the participants from all the phases in our study. So you will see that exercise begins at a low intensity and increases in intensity and duration gradually over a 12-week period. So intensity for the first 4 weeks was equivalent to 1 to 2 on the rating of perceived exertion scale. That's basically light to fairly light. While during weeks 5 to 8, the intensity increases to a level of between 3 and 4. That is moderate to somewhat hard. An RPE of 4 to 5, which is usually moderate to challenging, is maintained through weeks 9 to 12. And you can see that the duration of the endurance exercises also increases over the 12-week period from 10 minutes in weeks 1 to 4 to 14 minutes in weeks 5 to 8, and finally 20 minutes in weeks 9 to 12. The warm-up itself includes progressive exercises involving dynamic stretching and continuous rhythmic activities such as easy walking and toe and heel presses. The warm-up further includes rehearsal exercise sequences as well as joint-specific mobility exercises. You will see that endurance training encourages continuous rhythmic movement with the utilization of the larger muscle groups. The resistance exercises that are used are aimed to develop total body muscular endurance, strength, and power. Our panel of experts are also in agreement that all these exercises seen here were adequately sufficient. And they were also adamant that the static flexibility and relaxation activities at a low intensity during the cool down would be satisfactory to allow the body to adjust from exertion to rest. So I'm coming up to the conclusion. Like I've said before, the overall PhD project, as I mentioned, has culminated in various publications to each phase of the study. I'm also happy to report that it's all online and you guys can interact with it. And the developed model and the 12-week exercise prescription itself has proven to be feasible and cost-effective. It has been adopted by the relevant stakeholders and is currently being rolled out not only at the study site, but also at other rural and semi-rural sites around KZN. So we will be tracking the progress and hopefully reporting the outcomes soon. And that's the end of my presentation. Thank you. Okay, so we welcome to field some questions. If you guys can put them up on the chat, or I'm going to put my video on. And yeah, you guys can ask your questions. And I see that my professors are also here, so we'll be happy to answer any questions you might have regarding our research.
Levin, can I kick off?
Yes, you can, so.
Firstly, thank you to Helena and Matt and Caroline for setting this up. And nice to see some familiar names here. Thank you to everyone who's attending. Don't be shy to put your cameras on, everyone. Be nice to see some faces. So I'm sitting here. I know it's 30 degrees plus in Durban. I'm sitting here -10 in Canada. I've just been shoveling some snow. So often, particularly in sort of HIV research, there's been a tendency for us from the Southern Hemisphere or the lower middle income countries to follow what's being done in the Western world or the first world. But relating to your PhD, Levin, what do you think the first world or the more resourced world can learn from your study?
Thank you, Saul, for that question. I think it's a very relevant question. We often view our research through the eyes of the first world, and we don't take into context what we call lived experiences in our current country or in our relevant country or in the third world country. For me, it revolves around the stigma. It's not that easy for HIV people or people who are positive to actually decide that they need to, that the medication is available and they need to go and get it. There's lots of obstacles in the way. And one of the things that the study showed is that we keep going back to the same things in the form of something called stigma. The stigma attached to someone's positivity in HIV is a major concern. So it might be difficult for the first world to understand that. How come that we have medication available, but yet we're still not reaching out to the people we want to reach out to? And from the point of exercise, physical activity and exercise, we don't have that many areas that offer these type of rehabilitation services to our populations. So that's important. So the idea for my research is to actually not get the patients to come to us, but for us to go out to the patients. I think that's very important.
Thank you, Levin. And just to add to that, having been now in Canada for a while, I see there's a real need for that as well. That as much as places are better resourced, it's hard for people to get to hospitals, to get to let's say a physio practice, and there's really is that need for primary healthcare, for home-based care that your model showed. So actually, anyone throughout the world can learn a lot from your PhD, and just proud of you. I know Verussia as well. We look to you going from strength to strength. Well done. What a great presentation.
Thank you, Saul.
I hope you guys don't mind me adding that maybe it's a bit presumptuous for us to assume that stigma may not be a huge issue in first world countries, because spending some time with Saul and with other academics and with friends internationally, I also realized that it's a huge issue when you travel, and the huge thing that we need to overcome is the stigma, and we need to just get people to be aware. And I think education is critical for us in our context, for people to understand that HIV is a virus that can be treated, and we need to stop ostracizing and marginalizing people because of it. So we're busy right now with the randomized control test, and we're hoping that we can assist in even a small way, even if it's a model that can be replicated in other contexts, so people can understand that it's actually being exaggerated and we need to get rid of this stereotype around it.
Thank you, Verussia. There's a question on the chat, and it goes like this: how is the sustainability of the exercise implementation achieved? I think the question is by Nolutando Nzove. Nolutando, I've spoken about it in my study, and one of the things that comes to mind is training the trainer or task shifting strategies. I think that's very important. And the most efficient people or the most relevant people to take that forward will be your community healthcare workers. They are on the ground. So if we can actually train them to perform the exercises, to provide supervision, and to take on this task of implementing exercises for this population, I think that's way in which we can sustain it. So there's got to be this task shifting approach. We do have exercise specialists in the field. I know from my point of view, we currently have biokineticists and exercise scientists at those centers who are rolling out those programs. And part of their process is to teach community health workers how to supervise and how to go on with these exercises. So it must be sustainable over a longer period, not just a shorter period. I hope that
Hey,
answers.
Levin. Yes, thank you for addressing that. I was kind of looking for that differentiation of how is this going to be rolled out. So I think you've addressed the training of the caregivers, but also what you have answered, which was my other concern is, things change. Caregivers come and leave. Someone is sick. Whoever sort of knows what to do, they may not be present at the right time. And so then when you brought in, there are actual experts, because I found even in my past experience where we've also rolled out some exercises in old age homes, etc., and clinics. There is always some sort of breakdown that happens, and then we need to go back and as physiotherapists and actually do the same training. And so I think if there are specialists there that can every 3 or 6 months or something, then make sure that they maybe retrain or train the new staff or check that it's still actually being done the way that you've structured it, then that's good. That's the sustainability that I was looking for, that we're not just sort of, we've trained the initial group and then we kind of turn around and we're done, but that we're looking at, is it still being done well and correctly? So thank you for that.
Sure, not a problem. I see a hand raised, Professor Niri Naidu.
Thank you, Levin, and congratulations on your PhD, Levin. I don't think I've had a chance to personally say that to you. Well done. I'm especially proud of you because we go back a long way. So well done. And thank you to Sol and Borussia for all your support. I just want to say, if I may, disagree with you a little bit from the Durban perspective, having spent most of my life in Durban. If any of the attendees are wanting to visit, please don't give Cape Town a miss. That is probably for me the most beautiful part of South Africa. But I'm not there at the moment, Sol. I'm close to you. I'm in New York at the moment, so and we've got -12 today, and it's snowing heavily outside. So it's good to see familiar faces, and thank you again, Levin. There's just 2 things. I just wanted to say how pleased I am to hear you raise the point of social justice. Having spent perhaps 50% of my career in academia, I feel so strongly that those are, that's an important attribute for our graduates to come out with, to be able to recognize social injustice, and not just come out with an awareness of social injustice, but to be able to recognize it, be aware, and to act on it as well. So I feel as we go forward, that's something we really need to be focusing on with our graduates as well. Because if they come out, with an incompetence in that aspect, then we can't expect that they will react to all this wonderful work that you've been doing. I also wanted to raise the point that Noluthando did on sustainability. I've been involved with 3 projects. It's still in progress. One in KZN, where we have implemented an intervention program based on some pre-intervention measures in both rural and urban populations. And we found that actually the rural population was more lacking in physical activity. It's not specific to HIV, but the general population. And absolutely, I do want to give you full support. Our community health workers are our best bet to deliver these programs because they are on the ground, but they do need to be monitored. Another project that I'm involved with is in an intervention program with the Institute Palliative Care. And our community health workers are apt to do an absolutely sterling job. But you need to monitor them. They need to be updated with training. So it's up to us to be able to be present, to be there, to help to give them that support, to continuously provide that sustainability. But thank you very much, and well done, Levin. Always proud of you.
Thank you, Nuri, for that. I really appreciate it. So that gives people a reason to visit Durban and Cape Town. What better way to spend your holiday? Come down to the coast on both sides.
Sure.
Yep. I actually, there's something in South Africa, a word or a term that we use quite often in our communities, and it's called Ubuntu. It means I am because we are. And I think that's very pivotal to the type of research we do and the type of research we expose our students to. Going into these communities, trying to save these communities, trying to do research in these communities without losing track of who we are and why we are there and how we need to empower them. So I would say that the biggest term I would like to, or the biggest the biggest knowledge I'd like to impart on our students, especially in health sciences and rehabilitative sciences, is this term called Ubuntu. We go in there as health professionals trying to save or try to do good for these communities. And then, like you say, we leave and they're left to their own devices. So if we can incorporate Ubuntu into the way we teach, the way we do research, and the way we interact with these communities, I think that will actually go a long way to helping sustain these models as well. I don't see any other questions.
So I think there is one from Wes Naidu. Is that?
Sure.
Do you want to read that? It's the last one.
On the chat.
Yes.
Okay.
It's an interesting question about the AI.
Yep. So Mr. Naidu wants to know, could such a framework be conceptualized through AI platforms? Very interesting. In the current medical school where I work, they're actually trying to incorporate AI into the medical profession from a subjective point of view. So I'm not too sure, but it'll be something that we can look at. I think there are ways to blend AI into rehabilitation. I think we're not yet at a stage where we can be confident enough to do that. But yeah, very interesting. I wish I knew the answer to that question. I would like to say yes, but then rehabilitation is all about being in contact with your population and with your patients. So it takes away that personal factor, the personal touch. But yet we could still share the program worldwide or with people who want to use it in their own spheres. So yeah, I don't know. I think there's a bit of a yes and a bit of a no to that question, or as an answer to that question.
If you don't mind me jumping in there, Dr. Chetty.
Yeah.
So I think there is definitely room for artificial intelligence and AI in all of our approaches to medical health care and rehabilitation. Unfortunately, in the context that you are currently working in, it doesn't allow for that because of access and resource limitations. So we are struggling with issues such as water shedding and electricity issues and load shedding. And I think it's a huge challenge and obstacle for us that a lot of the world cannot identify with or understand, which makes it very interesting. So as much as the world is moving towards AI, and I mean, let's be honest, in the academic arena, it's easier for us to progress in terms of this because that's what we are now embracing in terms of teaching and learning and research. But where we work at this point in time and the context we're working in, it's difficult for us right now with the constraints we are under. So we need to figure out first how to combat issues of lack of understanding into the virus, etc. People don't have data, airtime. So unfortunately, on a ground level, that's not something we can really consider in your particular study. But yes, definitely in other projects that we are busy with, I could see it working in a more developed urban area. But the context that we are in, I really don't see that working at this point in time because there are other challenges and obstacles that we need to overcome, like getting a taxi and getting transport to the center where we're offering the exercises. But definitely in a more developed context, I think that AI would work, which we are looking at in another project.
Yep, I agree, Virusi. I think what constrains us is the fact that we look at low to middle income socioeconomic areas. So that's going to have a negative impact on introducing AI to those communities as well. Yep.
Okay, so do we have any additional questions from anyone? I think those were really good questions. And do you want to say something, as to conclude your presentation, or somebody else?
Yeah, I'd like to thank everybody for coming through. Like I've said, on the it will be recorded and it will be put out onto your platforms. So I am happy for people to contact our research group as well, and myself personally, especially if you need any of the articles that have been published. Some of them might not be accessible to you guys, so just drop me an email and I gladly email those articles to you guys. But yeah, thank you so much for the opportunity to present. And yep, that's it. Thank you so much.
Okay, so thank you very much, Dr. Chetty, for providing your presentation, and thank you for the HIV/AIDS C group for organizing this webinar. Thank you for all the attendees who joined us from different parts of the world. And as we mentioned again, this presentation is recorded and will be uploaded to our IPT-HOPE website, and I hope to see you in our future presentations, future webinars. Thank you very much.
Bye.
Thank you very much. Bye-bye.
Bye, everyone.
Bye. Bye. Thank you.
Bye,
Bye,
everyone.
everybody. Have a good day.
Yes. Thank you.
Thank you, Dr. Chetty. Bye, everyone.
Bye-bye. Thank you.
Thank you.
Okay, wonderful. Thank you again.
Thank you, Helena. Thank you for your time and for your effort. I appreciate it.
Thank
You take
you.
care. Enjoy. Bye.
Bye-bye. Thanks.